walking on the street and you have 100 people walking next to you, probably 3 to 8 they have ICAD with no symptoms.
I think some of our listeners might actually be happy because most of the things we talk about affect women more.
Yes.
Or
like
early
brain
on.
aneurysms, right?
Yeah, so
Right.
finally we're on the chopping block.
Yeah, so now the whole thing gets more balanced, I think.
Welcome to another episode of Brain Buzz, where we delve into the fascinating world of neurosciences and brain health. I'm your host, Dr. Kimon Bekelis.
And I'm your co-host, Jason Wallen.
And today we're going to talk, Jason, about intracranial atherosclerotic disease.
Or ICAD for short.
Exactly. I don't know that I could find a longer acronym
That's why we like
for this
ICAD.
podcast. And to get us through this difficult problem, today with us is Dr. Miklos Marosfoi. Thank you for being here, Miklos.
Thanks for having me.
So, we're going to start like we do with all our guests with a little bit of a background information on you. Our listeners and viewers have probably seen you before in some of our videos that we've released, but we've never really talked about who you are and what you're doing here on Long Island. So just as a bit of a short introduction, you guys know Dr. Marosfoi is my partner in the angio suite, and he's a neurointerventionalist, but I'm going to let you tell us a little bit more about who you are and what you're doing here.
Yeah, absolutely. So I'm a neurointerventional surgeon. I've been doing this for 20 years now.
Oh, boy.
And I came to Long Island from Beth Israeli Health, with all the experience. And we are building an amazing program here. And we're bringing new, procedures, new pathologies to be treated. And I think one of the most exciting one is basically ICAD, which I like a lot because it's a very difficult topic.
Right. And, I think before you came to Long Island, we didn't really treat much of intracranial atherosclerotic disease. And I think there were some evidence through clinical trials that kind of made us think one way, but of course, when you deal with pioneers like you, then we were able to see a little bit more of the choices that are out there and how we can treat disease. And let's start for our listeners with what exactly is ICAD? What is it?
Yes, absolutely. I think that's the right question to start the whole conversation. ICAD is a narrowing the brain arteries, which is basically buildup of a plaque,
Right.
which is very similar to other organs, like in the heart or in the leg or in the kidneys. Same thing happens. So this is a systemic problem,
Right.
and I would say if you're just looking at the brain, that would be the label
Right.
to the problem to the brain. It's an ICAD.
Right.
Same thing, heart, you get the plaque, you might get a heart attack. If you have some similar problems in the leg, you have pain while walking, other things. But we are mainly focusing here on the brain.
Right. And so what causes the narrowing?
So there is some cholesterol buildup. Is very commonly used term, the plaque. What is a plaque?
Right.
So there is some ongoing inflammation in the vessel wall. The fatty material is building up in the vessel wall, which creates a narrowing. We can go more in details about the mechanism, how we get from 0 to 100% of blockage.
Right.
And there are certain, I would say, steps when the plaque may become angry.
Right.
It's a higher risk for stroke.
Right.
So what's happening is a competition, I would say, is in between healing process is an ongoing inflammation.
Right.
So, the body senses there's something going on. I want to take care of it. And that's why we see many, many times small of calcium
Right.
inside the vessel wall, because that's part of the healing process.
Right.
So calcium is not bad. Actually, it shows that it's cooling down the problem. When we are talking about the inflammation in the very early stage, there is no calcium. There is no calcification in the vessel wall. And that's a very vulnerable plaque, I would say, which can create, a big problem. We are talking about stroke.
So what is the stenosis really made of?
So the The stenosis, when you're looking at the angiogram or any vascular imaging, basically you see a narrowing. But we know that behind the narrowing there is something else which makes it to look like narrowing.
Right.
And these are the plaques.
Okay.
The plaque is built up with, a cholesterol material, inflammation, inflammatory cells, and also some fibrotic tissue.
Right.
And all these things adds up to a point where actually you can see a narrowing, and that's
Right.
a problem.
Yeah, and it oddly sounds very familiar, right? For all you guys that know a lot about the heart and the blockages in the heart, that's very familiar to blockages in the heart. And so why are those narrowings important? Is it a lack of blood flow into the brain, or is it something else that's happening?
Yeah, I would say it's more complex than just thinking as a pipe which is clogged.
Okay.
And the reason I'm telling you, because even ICAD, which sounds basically like a one single pathology we're approaching, actually there are multiple ways that the symptoms can occur.
Right.
So one, what you just mentioned is that when the narrowing, gets tighter and there is no flow to the brain, that's what we call hypoperfusion. The brain is not perfused.
Got it.
So basically, we need more blood flow to that area of the brain, and the blood pressure cannot push through the narrowing.
Right.
That's when we don't have enough blood flow.
Right.
The other thing that in ICAD can become symptomatic
Right.
is when the plaque ruptures
Okay.
and is a blood clot building on the surface, and it travels downstream to the brain, and it clogs small arteries, which creates symptoms related to that area of the brain.
Right.
So one is not getting enough blood. The other one is you get a small blood clot downstream, and it's causing you a stroke.
So both are the mechanism. It's not just the decreased blood flow, but it can also be the fact that the plaque itself can change abruptly for whatever reason.
And we can go even further. So if the things goes even worse, then the plaque can 100% block the artery. And I'm sure we are going, or you guys already covered, LVO, large vessel occlusion,
Right.
meaning when the artery is 100% blocked.
Right.
And sometimes the underlying problem is the ICAD.
Right.
It's not the blood clot from the heart. It's
Right.
it's a local focal problem.
And just for our listeners to kind of sum everything up, when there's three really ways by which ICAD can cause a stroke, which is the big thing we worry about with these issues. And one way is hypoperfusion, or decreased blood flow, just by virtue of being a very tight narrowing.
Yeah.
The other is by breaking off pieces, sending them into the brain and causing a blockage all the way deep inside the brain. And the third one is by locally changing abruptly and rapidly, sometimes bleeding inside the plaque that makes it enlarge, or even clotting that happens fast where the plaque is, and shutting down that narrowing abruptly. So three very different ways: either a small vessel, small blood vessel stroke, or a large blood vessel stroke, or kind of a weird stroke of decreased blood flow.
Exactly. So why is this important? We are talking about these things because they need different approach.
Right.
So I don't want necessarily to jump to the treatment point, but actually this is how it relates, that we are talking about different mechanisms, and they really need different approaches.
Okay.
And when you're running a clinical trial,
Right.
You need to get the right patient in the study to get the right treatment. And that was the problem with the prior studies, which were not showing very high success because they pulled all the patient in one single trial.
Right. And before we talk about that, let's maybe backtrack a little bit. So in the heart, you have a narrowing.
Yeah.
The cardiologist shows up, no problem. They put in a stent. It's done, right? So I think that's a very common thing that we encounter. How is that different from our approach currently for the brain?
Yeah. So the brain, I would say, has a completely different approach because medical treatment is the first line treatment at this point. What does that mean? The patient has to be on antiplatelet medication, what we call blood thinners, and also anti-cholesterol medication, and what they say aggressive medical treatment, including all the risk factors: high blood pressure, diabetes, high cholesterol, has to be treated and hoping for that the stroke will not come back.
Right.
If that happens, then we move to the procedure side, and actually we are allowed to approach with a more invasive technique, doing angioplasty, meaning putting a small balloon up into the brain artery, inflating, dilating, opening up the artery, and leaving a stent behind to keep it open.
Gotcha. So
it's a longer I would say this is a longer process. There is certain scenarios when we have to move fast, even with the stenting, when actually the ICAD resulted in a large vessel occlusion, and we open up the vessel, and then we see ICAD, and then we want to fix that.
Right. So when you say antiplatelet medications for our listeners, what are antiplatelet medications? What medications do you have in mind when you say that?
So there was a big trial back 25, 30 years ago, which actually compared antiplatelet medication with other blood thinners, anticoagulation. And the whole point is, and the studies show that actually having antiplatelet medication is as effective as anticoagulation, but has less risk, meaning they're causing less brain bleed.
Right.
So the safety profile is higher. These medications are against platelet aggregation. So the platelets, they are not hugging each other, basically.
Right.
And they keep them aside, and that's one of the first steps of the clot formation. So if you can block that,
right,
the clot is not forming. So the blood can go easily through a stenosis, easily through a narrowing.
Right.
And if the plaque is inflamed and is very thrombogenic, it helps with that as well.
Right. What medications are those? What drugs are you talking about?
Aspirin is the one which I would say is everyone knows it.
Because everybody's asking us about aspirin all the time, but here's a good indication for aspirin.
Absolutely.
And then what other is commonly used?
Aspirin has many other good effects, but it's one of the, I would say, first medication. It's sort of indicated in ICAD. And there are other, I don't want to go into the brand names, but there are other medication which are similarly acting, but basically covering more. So the reason we're giving two medication, because we want to be 100% sure that they are really doing their job.
Got it.
The problem with the ICAD, and I think this is super important to touch the whole etiology and the possible risk with ICAD.
Right.
ICAD has a 20% recurrence of stroke.
Right.
If you compare it to the carotid, which is another big problem, which is more down in the neck. We're talking about two problems. One is down in the neck. The other one is more up into the brain.
Right.
Down in the neck needs procedure. We know all the parameters. I don't want to go into details, but the stroke risk is 2%. With ICAD, recurrent stroke is 20%.
Wow.
So it's very scary for a patient knowing that they have this pathology and they should expect a stroke in the next 2 years as high as 20%.
That is if they do nothing, right? If they just live their life, no change in risk factors, no change in medications, the risk in the next 2 years is 20. So 1 in 5. Yes. Which is extremely high.
And the other thing is that in the first 30 days, 1 month, first month, 50% of the strokes occurs.
After an initial stroke.
Yes. So you have the index stroke, the first one, which happens.
Right.
And the next one, without treatment, will happen in the next 30 days.
Wow.
In 20%. We're talking about the 20%. So that's why it's super important to get the right treatment from the beginning. There is no any reason for delaying medical treatment, and if it's necessary, then the more invasive surgical or interventional treatment.
Right.
So you talk about catching it in the very beginning.
Yeah.
Are there any signs and symptoms that somebody, that would lead them to get the imaging that you talked about?
Yes.
To say there might be something going on?
Yeah. So I would basically divide the patients in two big groups. One they never had any issues, any symptoms related to ICAD. This is what we call asymptomatic. There are no symptoms with that. The patient had a headache, got the CAT scan, got the CT angiogram. We'll go into that. What's that exactly? Basically, we want to image the blood vessels. And you find an ICAD. There is no connection with the headache, but it's there, and we say, okay,
Incidental finding.
Incidental finding. And in the population, we know that the ICAD is present without symptoms in about 3 to 8%. So if you're walking on the street and you have 100 people walking next to you, probably 3 to 8 they have ICAD with no symptoms.
Wow.
So it's out there. And then you have the other group of the patients when actually it becomes symptomatic. I would say if someone is lucky enough, probably they have a TIA, a transient ischemic attack, meaning they develop symptoms which can be a speech problem, it can be weakness, numbness, tingling, dizziness, walking imbalance, things like that. But it's very important it will last only for a couple minutes.
Right.
And this is, I would say, the first warning sign that something is not right. Other people who are not, I would say, as lucky, they might start with a stroke, which is exact as a TIA, but the symptoms are permanent. So that they are getting into, when we make the decision on when to intervene, when to do the procedure, I would say TIA stroke is equal. It's an event which it counts. And then you start aggressive medical treatment. And
Right.
if the patient is not responding well to the medical treatment, that's the time when we are actually getting into the surgical interventional arm.
Right. And so just again to summarize for our listeners, risk factors are very similar to cardiovascular risk factors, right? Same for the heart, high blood pressure, smoking, high cholesterol, diabetes, the big ones.
Yeah.
And then, of course, we have all the lifestyle modifications that we can do. What? Of course, if somebody has ICAD, they go into the best medical management, which is take the antiplatelet medications, aspirin, probably some other medication, get the risk factors control. What else can they do in terms of, because those are medical interventions, but in terms of their lifestyle, is there stuff they can do to control or contribute to?
So I would say there are modifiable risk factors and non-modifiable risk factors.
Okay.
You're touching basically the modifiable risk factors.
Right.
And I would add, lack of exercise,
Okay.
Not seeing a doctor regularly.
Right.
You can find, high blood pressure without, having symptoms. So
Of course.
it's a preventive measure to be there and be checked
Right.
regularly. And regarding the non-modifiable risk factors, we know that age is a factor. As we get older, our arteries gets more and more vulnerable, and the
Right.
plaque builds up. And usually, ICAD is not really for young patients. It starts around age of 50, 60.
Okay.
And it's getting worse over years.
Mm-hmm.
And there is a difference, a gender difference. So men, they have usually ICAD up approximately 10 years earlier than women.
Okay.
So that's also something which you cannot really modify at this point. That as a man, you probably will have a.
That's a disease we're not lucky with.
Oh, I mean, I think some of our listeners might actually be happy because most of the things we talk about affect women more.
Yes.
Or
like
early
brain
on.
aneurysms, right?
Yeah, so
Right.
finally we're on the chopping block.
Yeah, so now the whole thing gets more balanced. I think. I believe. Yes.
Bring balance to the force.
Are there any patient populations that are more susceptible to this?
Yes. In terms of ethnicity, absolutely yes. We don't know exactly why, but Asian, African American, Latinos, they have this intracranial atherosclerosis more often seen. If you want me to give you a number, the white population they have 10% from all the strokes. So you see all the patients, they have stroke. You find 10 patients with ICAD. And this numbers goes up to 35, 40% in Asian and African American population.
Wow, that's just 3 or 4 times more
Yeah.
common in that population.
I cannot blame everything on lifestyle, to be honest. So it has to be genetic and other things, which might play a role in these things. But this is very important when you actually see a patient and you think about it, that you probably, because your age, because your ethnicity, because all these non-modifiable factors, you have higher chance. So I have to take a look at your arteries non-invasively, if you have it or not.
And you had mentioned earlier there's other, you mentioned angiogram, but there's other imaging modalities. Can you touch more on that?
Yeah, so luckily I would say in the last 20 years, the non-invasive imaging, CT angiogram, which is a CAT scan with dye, and MRA, which is MRI, which focuses on the arteries, are the screening tools. We're not screening patients with angiogram. These are the tools where actually the patient comes to the hospital with symptoms. All the tests are done, run, and then we get the CT angiogram perfusion, and we see some narrowing in the brain. Angiogram is the gold standard to give you the percentage. It's a very accurate way to look at the ICAT, because some of the treatments are really goes by percentage. If it's a mild, moderate, severe, or 50, 70%, or more severe than 70%, that would put the patient in a different treatment category.
Right. Tell us a little bit about that. Tell us a little bit about the indications to intervene with a stent, and how does that relate to the percentage of the blockage in the blood vessel?
So I would say probably any treatment has their own best patient scenario could benefit the most from the procedure.
Right.
In this case, ICAD, balloon angioplasty, and stenting is the best for patient who has hyperperfusion. There is no enough perfusion to the brain because the narrowing is 70% or more severe than that.
Right.
Patients who had a stroke because the plaque involved the small artery next to it, which we call perforators.
Okay.
And it's not blood flow related. It's a local plaque problem. They would probably not benefit as much from this procedure,
right,
because they would benefit from medical treatment, because you want the inflammation to get down. The flow is not really an issue. It's a small artery which is trapped and it's closed. That's the big problem.
Right.
We cannot fix that with a stent and an angioplasty. So I think careful patient selection can give a lot of benefit to many, many patients to get the right treatment.
Right.
So indication, as we said before, is medical management. And if the patient, I don't like to say fail medical management treatment, they can be a good candidate for invasive stenting procedure.
Right. So there's a lot of nuances when it comes to these decisions. Not everybody is the same, of course, like you're saying. I think from all the diseases we treat in the angio suite, ICAT is probably the most nuanced and I think probably the most poorly understood in large scale. When you go into this detail, you understand who will benefit from what. But if you lump everything in one diagnosis, in one basket, it's all ICAD, not everybody will benefit from the same interventions. A question we get often, or a medication we get quizzed about often by our listeners is statins, right?
Yeah.
What is the role of statins in the treatment of ICAD? A common question I get in the office all the time is, if I go on a statin, will my plaque go away? Right? And then what is the purpose of putting somebody on a statin? Sometimes even if their cholesterol is not that particularly elevated.
Yeah, so statin has, other health benefits. We know that it has a effect on endothelial cells function. It has some sort of anti-inflammatory, effect. So that kind of, if you Google or you go YouTube, you see how can you remove your plaque from the arteries. I don't want to disappoint the listeners. You cannot, take a pill or just drink a cocktail or something and you're dissolving the clot or the plaque.
Right.
What you want to have is to get an inflamed plaque into a stable. Basically, you want to stabilize the plaque.
Right.
So when you're taking statins, when you're taking other medications, the goal is to cool down the plaque. That's the thing. So it has a benefit. It's not just you have high cholesterol. Of course, that's the primary indication, but also it helps to stabilize the plaque. How do you know that your plaque needs to be stabilized? That would be the next question.
Right.
So the way you try to understand that there are vessel wall imaging technology out there, which is high resolution MRI,
Okay.
and the plaque lights up on these imaging, meaning that is more willing to take up dye and is more in an inflammatory stage. So if that helps to decide between medical and invasive treatment, that would help. Because if the plaque inflamed, yes, you go statins, you go antiplatelet medication, and you try to get the inflammation out of the way.
Right, and that's not common, right? These MRI tools that you talked about, they're more investigational. I
Yes,
understand.
exactly.
Yes.
I believe in a couple of years, hopefully, we can get there. That is going to be part of our diagnostic,
And that would be
options.
even more nuanced, going into understanding the plaque itself. And I think to some extent the holy grail when it comes to all of us treating plaque, vascular surgeons, cardiologists, neurointerventionalists, we all are trying to understand plaque, when we're treating it at the carotids, in the carotids or in the legs, we're trying to understand what plaque is dangerous, what plaque is not, what plaque can benefit. Of course, we use right now, the easiest way to understand plaque is the degree of blockage, 70%, less than 70% when it comes to the carotids. And I think, and also in the heart, that's probably the biggest indicator for friable or unstable plaque. But then there's so much nuance to the rest of the plaque characteristics.
Absolutely, and this is coming. So I was lucky enough to work a couple of years with OCT, optical coherence tomography, which I believe that's another game changer for the neuro field.
Can you explain what that is?
Yeah,
for
what
our
is
listeners?
OCT?
You said a mouthful.
Yeah, it is. So basically what you're doing is it's optical. So you shine the light through the vessel and you get it back. It's very similar to an ultrasound, but it's not ultrasound. It's an optical thing. You shine the light like a laser, and you get it back, and then it tells you...
Endovascularly?
Yes.
Okay.
So you put the whole... It's a very, very thin wire. You go all the way through the brain where the plaque is, and you do the imaging. Basically, what you see is, in a very, very high resolution, the consistency of the plaque. How much lipid, how much cholesterol, how much fibrin, how much calcium there is. And even while doing the procedure, if you have this at hand, it will guide you how aggressive you can be with the procedure. Because we learn more and more. It's very important, I would say basic physical knowledge. If you open up the vessel just a bit, the flow is much more than that. So basically, it's probably safer not to open up 100%. It's safer to open up 80%, 60%, because the flow is going to be enough for the brain. But you're not pushing plaques in small arteries. So it can guide to make the procedure safer.
Now, I think that leads into some of the common questions or some new questions even that we've got from our listeners. The prognosis for somebody with ICAD, what are we looking at?
Yeah. So I think we mentioned the numbers, that the 20% with stroke recurrence. It seems that recently we have seen very encouraging clinical trials with invasive treatments, angioplasty stenting, bringing down the stroke risk around 2.5%. So we're comparing 20% to 2.5%. So there is treatment for ICAD. It's not easy. The decision making is not easy. It's a long process. But I see that we're getting there. We're getting to the point that we can safely treat this very difficultly treated, disease.
And how long, when a patient's on the dual antiplatelets, how long do you think that is effective for? Do we say?
So the current guidelines really say that they have to be for 30 days for the first month, because as we said, 50% of the stroke happens the first 30 days. What I believe we have the advantage of the other specialties comparing to other specialties is actually we see the blood flow while we are doing the angiogram.
Right.
We're seeing the morphology of the plaque. We have a much more accurate measurement of the stenosis. So sometimes I think in specific cases, dual antiplatelet has to go longer. It's maybe 1 year, maybe 2 years.
How long can that treatment option, do you think, last over where it has to then cross over to stents and angioplasty?
Yeah, so we're circling back a little bit to the inflamed plaque. So if you can cool down the plaque, probably it's okay to continue with aspirin, which is one medication instead of two. If it's a battle which you cannot win with medication, then you can get the procedure. When? Nobody knows. When the patient becomes symptomatic again, you cannot predict. But we know that, and the patient knows, that we are ready for this. We are ready to take her or him, get in the angio suite, and we know what kind of treatment can we do. So actually, the conversation starts way before. So when I see patients in the office with ICAD, the conversation covers everything. Covers that you have this one, you might never ever had another stroke, or we are ready if something happens to provide you with the best interventional treatment possible.
And that goes into one other question, and actually we experienced this I think the other night. A lot of patients are reluctant to want to have stents because they're afraid for different reasons. What would you say to that patient?
I think it's all about the right indication. If the patient needs a stent. We don't have better than that, and we know that the recent data show that the risk is going down significantly. So we can tell the patient that stent is safe. Probably better to be treated in a center which has very much experience. Interventionist, and we are lucky to be that kind of place.
Right.
So that also something which the patient has to know.
And tell me about asymptomatic ICAD. Would you start medications for these folks? And when would you? Is there some people that you would say, it's too mild, I'm not going to start any medications, or this is significant? Or is there any evidence?
There's not much evidence on that, but I would say if you would ask me what would I tell to my family members, I would probably say we have to look into statins and we have to look into aspirin.
Okay.
So I see much more benefit than downside of doing that. And why would I wait, to have something become symptomatic? It's if I already can help, and again, it's a red flag. So you have to do something with your risk factors, because otherwise this is going to be a big problem in the next 5-10 years. That is super difficult. When I have a conversation with a patient, it's always difficult to get to the point that we are talking about problems which will maybe happen in 5-10 years.
Right.
So you have to take care of yourself right now, because it will be something in 10 years, and we are not good on that.
Right, and it's common, unfortunately, when it comes to atherosclerotic disease across the body and plaque buildup. It's common to tell people to modify their behavior today for a reward that's going to come 20 years down the line.
Super difficult.
And when it does come, there's no walking back from it. Once the plaque is built, that was the point I was making earlier, it doesn't go away.
No.
And often patients wish that, but it's nothing more than wishful thinking. Once the plaque has developed, once the inflammation has taken hold, you're playing catch up, and what you're trying to do is to manage a diseased vessel and prevent a catastrophic complication. But the best treatment, like most things, when it comes to ICAD, is prevention.
100%.
Is what's going to put us out of business. Meaning, if you control your risk factors before you have to control your risk factors, if you watch your diet before you have to watch your diet, if you exercise before we ask you to exercise, if you quit smoking or never smoke, you're going to have a much longer life, because your vascular health, which is one of the most important factors when it comes into, longevity, is going to be much better. And talking about all these issues, also commonly patients ask us about, dementia. And of course, I am sure we're going to get questions about dementia and ICAD and how do they two relate to each other. Do you want to comment on that?
Yeah. So it's a very, very good point, and I think it's probably is getting more and more topic of discussions, because we're an aging population.
Right.
So at some point we all will have some sort of ICAD. And when someone has no enough blood flow to the brain, it affects the so-called white matter. It's a deeper structure of the brain.
Right.
And it's a very interesting number I've read recently, that they looked into patients with dementia, and 35% of the patients had ICAD or some sort of intracranial stenosis.
Okay.
So it's probably is more frequently out there than we thought before.
Right.
And we know about Alzheimer, we know all the other dementias, but we should not downplay the vascular dementia, connected to any ICAD or intracranial pathology vasculopathy problem.
Right. And I think a lot of this stems from the fact that there's no successful treatments for dementia for the long term. And whatever treatments we have, they work in the short term, but they're the same no matter how the dementia developed, right? Was it Alzheimer's? Was it vascular dementia, like you're mentioning, or some other neurodegenerative disease? So all these, they're different etiologies, but when it comes down to treating them, it's the same treatment, which is limited, and then the outcome is largely the same. But it is important to understand how we got there. And vascular dementia is probably a lot more common than people know. The challenge with vascular dementia is the same thing. Atherosclerosis cannot really be reversed. And when mankind develops an effective treatment for dementia, vascular dementia will probably be the most resistant to treat because of its impact on the brain, the multiple strokes, the disease of the blood vessels. So again, looking for a treatment for this particular pathology, look no further. Work into prevention. Prevent your blood
100%.
Vessels from turning into, plaque-laden blood vessels, and have a healthy lifestyle, I think, is kind of the message.
Yeah, absolutely. I agree with you. It's a very difficult topic, I would say, preventive medicine, because,
Because these issues, don't hurt.
Yeah.
If there's no pain, patients tend to not want to follow necessarily a path. There's no kind of the risk-reward mechanism doesn't work that well. And
it comes down to paying the piper later.
Exactly.
For what you want to do today or yesterday. I mean, we see that as we're all getting older.
Right.
You have those aches and pains come up, and from doing sports when you were younger or whatnot. So,
I'm not getting older. I have no idea what you're talking about. Perfect. Anything else, Jay?
No, I mean,
super. Well, Miklos, thank you so much. This is a very interesting topic and a very complex topic, and I think you broke it down to its basic components very nicely, and helps us understand it better, and I'm sure our listeners even better. Of course, guys, if you have any questions, you can always reach out to us through social media. Thank you again for listening in, and we'll see you again on another episode. Take care.